Hello and welcome to Pace Hospital's podcast. Today, we are diving deep into a condition that often hides in plain sight, that is, chronic pancreatitis. This long standing inflammation of the pancreas can be painful, progressive, and life altering, affecting everything from digestion to blood sugar regulation. Joining us today, Dr. Govind Verma, an interventional gastroenterologist, transplant hepatologist, and endosonologist with vast experience in diagnosing and treating pancreatic disorders. In this episode, Dr. Govind Verma will help us understand what chronic pancreatitis is, the early warning signs, how it is diagnosed, and modern management options, including dietary changes, enzyme therapy, and minimally invasive procedures. Whether you are a patient or a caregiver or simply curious about pancreatic health, this conversation will help you to decode this complex condition. Dr. Govind Verma, thank you for joining us at Pace Hospital's High-Tech City. Let's start by understanding what is chronic pancreatitis.
Hello everyone, I am Dr. Govind Verma, consultant gastroenterologist and hepatologist at Pace Hospitals, Hyderabad. Today I would like to talk about chronic pancreatitis, a condition which is prevalent in our country and many patients are suffering with this disease. We should know more about this disease is what I thought. So we are discussing in detail. We know, as we all know the word chronic, it's a chronic inflammation of pancreas leading to progressive permanent loss of pancreatic function. So the commonest question which is asked to us is what is the difference between an acute and a chronic pancreatitis? As the word defined, acute is basically an inflammation of the pancreas within 4 to 6 weeks period, which is completely reversible. Whereas chronic pancreatitis is over a period of months and which is irreversible. So this is on a broader definition and broader difference, although there are many subtle differences which are there, which I would like to discuss when we discuss it further.
Dr. Govind Verma, what are the common causes of chronic pancreatitis?
The common causes of chronic pancreatitis are alcohol, then recurrent attacks of acute pancreatitis, obstructive causes like malignancy, which can lead to, then there is a hypertriglyceridemia, induced chronic pancreatitis, pancreas division leading to chronic pancreatitis, hereditary pancreatitis. Idiopathic is a big chunk of population who can present with chronic pancreatitis. There is a special condition which is seen in southern belt called as tropical pancreatitis. So these are the few common causes of chronic pancreatitis, and the question remains how much alcohol can cause chronic pancreatitis. So as we all know that the quantification of alcohol in a chronic pancreatitis is not in the one-time quantity, although as I mentioned earlier in my earlier talks, binge of alcohol, a large quantity of alcohol can cause acute pancreatitis, but for chronic pancreatitis, the intake of alcohol has to be over a period of years. So it can be for 5 years or 10 years or more, where these patients can lead to chronic pancreatitis.
Could you explain what are the symptoms of chronic pancreatitis?
So we'll discuss the symptoms of chronic pancreatitis. First and foremost symptom is abdominal pain, which is usually in upper abdomen, and we call it as epigastric or left hypochondrium and radiating to the back. The pain can be intermittent or can be continuous for days together. The second symptom is patient may have a nausea, vomiting. As the disease progresses, patient may have developed symptoms of malabsorption, diarrhea, weight loss, and so on. Some patients who present with complications of chronic pancreatitis may present with jaundice or distension of abdomen.
So doctor, what are the potential complications of chronic pancreatitis?
So why are we discussing chronic pancreatitis today is because of the potential complications it can cause to the human life. As we all know, chronic pancreatitis is basically a progressive permanent loss of the pancreatic function, whereby the exocrine and endocrine functions of the pancreas get affected and thereby causing different complications which may be related to the structural, which may be related to the functional capacity of pancreas. When it comes to the structural complications, Chronic pancreatitis can cause ductal stricture, thereby causing repeated episodes of pain. It can cause multiple stricture at different length interval, giving a chain of lake appearance. It can also cause a wall of necrosis when there is acute attack on a chronic pancreatitis. We call it as pancreatic collection or a pseudocyst. This pseudocyst or this collection can compress on a nearby structure, causing jaundice by causing obstruction of the bile duct. This can also cause inflammatory response and can affect the nearby vessel, causing portal vein, splenic vein, superior mesenteric vein thrombosis, and development of abnormal esophageal varices or gastric varices, thereby causing GI bleeding. Long-term pancreatic functions can get affected, which are exocrine functions, which can also affect the which can also present with malabsorption like vitamin A, D, E, K. Some patients, because of the affecting endocrine function of the pancreas, can present with diabetes. We call it as type 3 brittle diabetes because they are usually difficult to respond. Some patients can have a chronic diarrhea and malabsorption syndrome kind of presentation. So by and large, the patients can have a variety of complications. Keep in mind, chronic pancreatitis is also a precancerous condition. Some patients of chronic pancreatitis can progress into a condition called as cancer of pancreas. So it's very important for us to diagnose chronic pancreatitis in time and keep it under surveillance to diagnose early cancer of pancreas, which can be treated and can be resected if it is diagnosed early.
Can you explain how is chronic pancreatitis diagnosed?
The next question comes into mind is, once I know that my symptoms are of like chronic pancreatitis, how do I diagnose it? So there are a variety of tests which are available. Apart from the routine blood tests like a routine health checkup which we do, specialized test I would like to discuss. A simple X-ray abdomen can show you the calcification of the pancreatic stones in the form of shadows, white shadows on the X-ray. We can also detect various findings on an ultrasound of abdomen, which can show you the pancreatic size. It can be an atrophy of pancreas. There can be a ductal changes in the pancreatic duct, whereas in a patient of chronic pancreatitis, because of the ductal obstruction, there can be a duct dilatation and stricture formation. As I mentioned before, we can see also calcification in the body of pancreas, or we can see stones in the pancreatic ductal system. There can be also a detection of mass in the pancreas, most commonly in the head or body of pancreas, once the pancreatitis sets into malignancy. There can also be, as mentioned earlier, thrombosis of superior mesenteric vein or portal vein or nearby structure inflammation. We can also detect on ultrasound a collection which we call pseudocyst if it is non-necrotizing, or it can be a walled off pancreatic necrosis if there are debris and necrosis in it. So we can detect many things on an ultrasound. It's basically a screening test to know whether the patient can be suspected to have chronic pancreatitis or not, although it is not the only diagnostic test. It can be still normal and patient may have a chronic pancreatitis. The third test which we do is CT scan of abdomen, which gives a variety of information right from the size of pancreas, ductal length, the ductal diameter, then strictures, number of strictures, size of stones, location of stone, and then it can also give you mass of the pancreas, vascular structure nearby, can give you information about the bile duct, can also give you information about the surrounding compression by the collection. So it's very important. CT almost gives you a near complete picture of the chronic pancreatitis. The most specific test which we used to do before the MRCP advent was ERCP, but because of its aggressive and invasive nature, it is no longer used for the diagnostic purpose. However, it is getting replaced by two different tests. One is MRCP, magnetic resonance cholangiopancreatography, whereby we can get the bile duct and pancreatic duct details. We can know the ductal diameter in detail here. We can also know the ductal stones if they are there. We can also comment about the mass in the pancreas in detail. Similarly, one more promising investigation which has come up in recent times is endoscopic ultrasound, whereby we would know the micro details of the pancreatic parenchyma. We can know the mass in the pancreas, we can know the ductal diameter, ductal stricture, we can know the ductal stones, location of the stone, and so on. It also helps us in therapeutic drainage of the pancreatic duct if required. So it has a diagnostic and therapeutic application. It also helps in treating the complications of pancreatitis like walled-off necrosis. We can drain with the endoscopic ultrasound method. We can stain through the ultrasound method when the routine conventional ERCP fails. Fourth investigation which we can do in patients of chronic pancreatitis is stool examination, fecal elastase estimation, and other tests which are for malabsorption tests like vitamin A, D, K. We can do LFT, we can do CBP, we can do stool examination for fat globules to see a condition called as steatorrhea, where because of the lack of enzymes, patients may have a greasy, oily stool, odorous stools, and that is because of the malabsorption of fat. Patient may have a steatorrhea that can be diagnosed by a quantification of stool fat for 72 hours. We can do that specific test in given patient. Apart from that, we also do in a suspected patients who have a chronic pancreatitis with cancer of pancreas, CA99. It's a tumor marker which gives you the suspicion of impending CA pancreas, provided the clinical picture, the radiological picture like CT, MRI matches with the suspicion of pancreatic mass. But sometimes CA99 can get elevated in an acute attack of pancreatitis on a underlying chronic pancreatitis. So we have to be very careful and watchful about interpretation of the CA99 in a patient of chronic pancreatitis.
Doctor, can you briefly explain the pathophysiology of chronic pancreatitis?
Basic why there is a acute pancreatitis and why there is a chronic pancreatitis. What happens exactly in these two conditions? Pathophysiology when we want to discuss. In acute pancreatitis, there is a autodigestion of pancreas. What does it mean? It means that the pancreatic enzymes which are in a precursor form, we call it as zymogen from acinar cells, they get released prematurely and they digest the pancreatic parenchyma because of the premature release of these enzymes, and they get activated into the parenchyma of pancreas. So it's an acute pancreatitis, whereas in chronic pancreatitis, its theory is because of the alcohol, smoking, then trypsinogen activation. It can be hereditary, it can be genetic reason, so-called, so on. All this, what it causes the basically release of free radicals, and thereby pancreatic stellate cell get activated. Once the pancreatic stellate cell get activated, free radicals or oxidants get released, and they release cytokines, and it is the balance of antioxidation and pre-oxidants which decides the fate of the patient. So if the oxidation is more, then the stellate cell will lead to fibrosis, so ductal stricture, thereby causing ductal dilatation, thereby causing ductal hypertension, release of again zymogen, again repeated attacks of acute pancreatitis. So it's basically in chronic pancreatitis there is a stricture, there is a fibrosis, there is atrophy of pancreas, whereas in acute pancreatitis only inflammation there. So there is no structural damage to the pancreas except the bulky pancreas or inflammation of the pancreas, whereas in chronic pancreatitis, the entire parenchyma, the duct, the acinar cells, the exocrine, endocrine, everything gets affected.
Dr. Govind Verma, what are the treatment options for chronic pancreatitis?
If you want to discuss about the treatment options of in a chronic pancreatitis, they are divided into three parts. One is a medical treatment. We all know that patients of chronic pancreatitis have abdominal pain as a presenting symptom. Apart from PERT, there are few medications which have been tried and have been found successful, like antioxidants, methionine, and with the dose of 2 grams per day. There are enough trials which have shown that is useful, because oxidation is a theory for the cause of chronic pancreatitis. So because of oxidation as one of the important theory in a pathophysiology of chronic pancreatitis, antioxidants like methionine, vitamin C, vitamin E have been tried for the relief of chronic pancreatitis and have been found to be useful in young patients who are non-opioid and who are non-alcoholic. As a reason, they respond well to the methionine. There is one more theory which is called as neuropathic theory, where the pain is because of the neurological transmission of the pain from the celiac ganglion and other ganglions to the brain, and there is a loss of inhibitory descending response which gets controlled by, or which gets reactivated, because there is a loss of inhibitory reflex, so pain is perceived more by the patient. It's called as chronic pancreatitis neuropathic pain, which gets relieved by pregabalin. So a patient who comes to you with a chronic pancreatitis, first option, medical option, one is a PERT, like pancreatic enzymatic replacement therapy. With each meal, we give pancreatic enzyme supplements, which helps in the digestion. Second is we give some patients who are non-alcoholic, who are young and who are non-opioid analgesic dependent. They can be given methionine along with pregabalin. It works wonder. Apart from this, there are other modalities of treatment like endoscopic treatment. Now, what do we do in endoscopy? We know that in chronic pancreatitis, there is a ductal stricture and there are stones which are causing ductal stricture more symptomatic. So our aim is to drain the pancreas. So when we have a patient who has a ductal stricture, ERCP and stenting can be tried. For those patients who have a 1 or 2 soft stricture along with the stones which are lesser than 5 millimeter. All these patients, we can do a ductal dilatation. We can retrieve the stone by ERCP and pancreatic sphincterotomy and placing the stent. Those patients who have a stricture which is larger than, who have a stone which is larger than 5 millimeter, we can do ESWL for those patients. We can break those stones in different sittings, can pulverize the stone less than 3 millimeter, and then we can remove the stent by doing an ERCP and doing a balloon sweep followed by a stenting. There are enough trials now which have shown now there is a role for spyglass laser lithotripsy. We have been doing that kind of treatment, and we have observed that those patients who have a large size stones, who have stones in the head or body of pancreas, and those who have multiple stones, even we have removed stones which are 2 or 3 or 4 stones in one area or maximum in head and body with the dilated duct. We have seen that the patients have responded very well. In 1 or 2 sittings, we have cleared the pancreatic duct. So that is one of the upcoming treatment in patients with chronic pancreatitis, which doesn't need to be undergoing ESWL. The advantages of spyglass laser lithotripsy, pancreatic lithotripsy, are that we do a direct visualization of the pancreatic stones. We can target the stone under vision. We can see the stones be getting fragmented. We can go into the sub branches if required. We can also do a balloon clearance in the same sitting. And there are some patients who have limitations, that where we cannot do is the patients who have stones in the tail of pancreas, in the body and head, all throughout the pancreatic duct. If there are stones, then we cannot do this procedure. These kind of patients with multiple strictures and head, body, tail, we can subject them for a surgery like LPJ we call, or modified Frey's procedure. Lateral pancreatic jejunostomy or a modified Frey's procedure can be done for the patient who have multiple stricture along with the stones. But whereas those all patients who have a duct which is dilated and stones are limited to head and body, 1 or 2 strictures can easily be managed by the endoscopic therapy. We call it as pancreatic endotherapy. We divide pancreatic endotherapy in 3 parts. One is ESWL, second is laser, spyglass lithotripsy, third is EHL. All have advantage over each other. We have to select the patient based on the patient's reports and clinical condition. There is a superiority of one or the above. Laser spyglass has been shown to be very superior as compared to other modalities of treatment in terms of pain elevation. Now, third is when you want to treat the complications of chronic pancreatitis, there can be a cirrhosis, there can be a walled-up pancreatic necrosis. Now, for these kind of complications, previously laparoscopy was only the option available, or open surgery. Nowadays, we can do endoscopic ultrasound guided drainage of these collections, whether it is a pseudocyst, we can do with the plastic stent. If it is a collection which is walled up pancreatic neoplasms with debris, we can use a lamps called as lumen opposing metallic stent. Like we can do hot axios, we can do nitius. All these kind of metal stents adhere to the cyst wall on one end and stomach wall on the other end. They are large size, wide calibered, around 2 to 3 centimeter wide stents are available, which can easily drain the pancreatic fluid, infected fluid, and we can go through the stent with the help of the routine endoscopes and then can do a necrosectomy if required. So these kind of modalities are very much available now, and they are easily being done in various centers. The other treatment modalities which is available for the chronic pancreatitis is surgical treatment, wherein the patient can be subjected for laparoscopic or open pancreatic ductal drainage methods. The most common is lateral pancreaticojejunostomy, or the patient who go with the head core resection along with the lateral pancreaticojejunostomy, we call it as Frey's procedure or modified Frey's procedure.
Can you explain what foods should be avoided with chronic pancreatitis?
We often get questions from the patients and relatives, what is the diet for a chronic pancreatitis? By and large, those patients who have chronic pancreatitis, we advise them to take low fat diet. The diet which is less with oxidants, so we avoid junk food, we avoid fatty meal. We also ask them to take frequent meals rather than one time large quantity meal. We tell them to avoid smoking and alcohol because they are the risk factors for the repeated attacks of acute on chronic pancreatitis or acute pancreatitis. So they should avoid smoking and alcohol by default. Apart from that, most of the patients, almost 50% of the chronic pancreatitis patient may have a diabetes mellitus. So that's why most of the time they will have a low sugar diet, we can call it as. So in summary, it's a low fat, low sugar diet, and we also want them to be avoiding the smoking and alcohol consumption.
So doctor, who is at risk of developing chronic pancreatitis?
Patients also ask many a times why I have developed this chronic pancreatitis. Those patients who have consumption of alcohol, those who are smokers, those who have a family history of pancreatitis in their family, those who have trauma, those who have a high triglyceride content, those who have a high calcium content in their blood, they all are at risk of developing chronic pancreatitis. And fortunately, these all patients, if we diagnose them well, if we diagnose the reason for their chronic pancreatitis, we can treat them. But there are few conditions, we call it as idiopathic or genetically transmitted condition like cystic fibrosis or SPINK1 mutation, where we can't do anything because there are genetic reasons where they are not reversible. So these patients are left to the destiny. But otherwise, most of the patients where there is a etiological reason found, like pancreas divisum, or for that matter, we can treat all of them. We can treat their complications. In case they develop complications, even if we are not able to treat the reason for their development of chronic pancreatitis.
Is chronic pancreatitis a common condition?
Chronic pancreatitis is basically common in males than females, 2:1 ratio, and it's like 40 to 150 patients per 1 lakh population. That's a prevalence which is seen of chronic pancreatitis in different population.
Dr. Govind Verma, can chronic pancreatitis be cured?
So patients innocently ask us many times, can chronic pancreatitis be cured? I want to tell them that chronic pancreatitis is basically, the word itself suggests that it is not curable, but it is treatable. So the patients who have no pain but dilated duct and stones, we don't need to treat them. We just need to leave them, and we need to treat them, their complications, if at all it is needed. Like if they develop diabetes, then we treat aggressively. If they develop any other symptoms, then according to the reason of that symptom, we treat them. But by and large, chronic pancreatitis is an irreversible condition. It can be treated though completely, provided we diagnose it in time.
So doctor, can chronic pancreatitis lead to pancreatic cancer?
Chronic pancreatitis is a pre-malignant condition. almost 4% of the patients who have alcohol as etiology for chronic pancreatitis, they develop over a period of 15 years pancreatic cancer. Whereas if you have a genetic reason like SPINK1 mutation, the same percentage go to 15 to 20% of the patients of chronic pancreatitis can develop over a period of 15 years CA pancreas.
Does obesity increase the risk of chronic pancreatitis?
Obesity doesn't increase the risk of chronic pancreatitis. Most of the times, patients of chronic pancreatitis have history of weight loss because of malabsorption, and they are usually emaciated or malnourished because of chronic pancreatitis. Obesity per se doesn't cause the chronic pancreatitis, but yes, if you have a high triglycerides, it can cause chronic pancreatitis. And most of the patients who are obese may have a high triglyceride. Very high triglyceride only can cause chronic pancreatitis. So again, they're above 500 or 800 milligram percent triglyceride level need to be there to cause it at triglyceride induced chronic pancreatitis. So in summary, obesity is not a risk factor directly for chronic pancreatitis.
Can chronic pancreatitis cause liver damage?
So chronic pancreatitis, can it cause liver damage? Directly, it doesn't cause liver damage, but then if the chronic pancreatitis is associated with the complication like bile duct stricture or the pancreatic stricture, these all complications can lead to secondary biliary cirrhosis. And many times if the reason of pancreatitis is alcohol, it can also cause liver disease. Alcohol can also cause liver disease at the same time. So we are seeing many patients who have a alcoholic liver disease, they also have alcoholic pancreatic disease. So because of the common etiology, yes, it can be shared, but per se, it's basically a complication of chronic pancreatitis which can lead to secondary liver disease.
Does alcoholic consumption increase the risk of chronic pancreatitis?
It's basically alcohol consumption over a period of years, 10 to 15 years, a cumulative risk of developing chronic pancreatitis increases. And that is how repeated attacks of acute pancreatitis because of alcohol intake lead to changes in the ductal hypertension, changes in the duct diameter, thereby causing fibrosis and developing chronic pancreatitis. So it's basically a cumulative risk of long-term alcohol intake which leads to chronic pancreatitis.
Is there a risk of malnutrition with chronic pancreatitis?
So as we all know that because the pancreatic gland has exocrine function and endocrine function, the loss of exocrine function, which is various digestive enzymes are released like chymotrypsin, trypsin and amylase and lipase. All these enzymes are essential for digestion of carbohydrate, fat and protein. Once the exocrine function is lost because of chronic pancreatitis, which may be from 50 to 70 or 80% of the pancreatic parenchyma loss and the function is lost, then it leads to malabsorption of these essential food like either it's a carbohydrate or it's a fat or protein, eventually leading to malnourishment and malnutrition and weight loss.
Dr. Govind Verma, does chronic pancreatitis cause diabetes?
Yes, chronic pancreatitis causes diabetes because of the loss of endocrine function. We know that there are two main cells which are called as alpha and beta. Alpha secretes glucagon and beta cells insulin. So because of the loss of acinar cells and endocrine synthetic function in patients with chronic pancreatitis, patients of chronic pancreatitis develop brittle diabetes or type C diabetes, which is difficult to treat diabetes. And that's why many patients get diagnosed having pancreatic disease after they get to know that they have high sugar level, and then they do ultrasound, and that is where they get diagnosed that they have a chronic pancreatitis as for their reason of developing diabetes mellitus.
So doctor, can chronic pancreatitis be managed without surgery?
All chronic pancreatitis patients do not require invasive treatment or surgery. Almost 30% of the patients can be managed by medical treatment, and there are special medications which are available. There are enzyme replacement therapies available. We call it as PERT, pancreatic enzymatic replacement therapy. There are some medications which are available like antioxidants, methionine or pregabalin, which can be given for the pain. There are special endoscopic semi-invasive procedures are available for elevating the pain called as celiac axis block, celiac ganglion block rather, and only few percentage of patients who develop complications require surgical intervention or endoscopic therapy for their complications or treatment or elevation of the pain.
Can you explain when is surgery required for chronic pancreatitis?
Many patients ask us what will be my prognosis, whether I will require surgery when I have already developed a chronic pancreatitis. So there are few surgical indications which are clearly defined. The patients who have a chronic pancreatitis, who have multiple strictures in the duct, who have very large stones with multiple stricture like chain of lakes, those patients are subjected usually for the surgical intervention. Those patients who have a mass in the pancreas along with the underlying chronic pancreatitis, those patients also are candidate for surgical resection. Few patients who have a collections or wall of necrosis which is in the paragolic gutter, or those which are in the tail region which are not accessible with the endotherapy, are again candidate for the surgical drainage. So there are few indications which are definitely there, and we play teamwork when it comes to the treatment of pancreatic disease. It's basically a team of medical gastroenterologist, surgical gastroenterologist, pancreatologist, and intervention radiologist who work together to make a patient success.
Thank you, Dr. Govind Verma, for sharing crucial information regarding the chronic pancreatitis to our listeners. If any of you have any further questions regarding chronic pancreatitis, please don't hesitate to consult a gastroenterologist. Remember, effective management begins with awareness and education. We will see you soon on Pace Hospital's podcast with another episode. Until next time, stay curious, stay informed, and stay healthy. Thank you.